Hello everyone, I am Rima Abu Milha. Today me and my colleagues Shahad Al-Ghamdi, Lamis Dghariri, Nofer Rukban and Asma Al-Ajmi will present our case presentation. I will start talking about the general data. Patient's age is 30 years old, gender male. Patient's chief complaint. He came with discomfort in the maxillary right area. The history of present illness. There is discomfort in the upper right area. Past medical history. Patient undergone prosthetic valve replacement surgery 1 year ago. Past dental history. Radiographically shows that there is restoration in tooth 1.5 and 4.6. Family history and habit history are not mentioned. There is two types of radiographic projection were taken, periapical view and CPC from two angles. Now I will talk about the radiographic interpretation. Location is in the maxillary right side. Site is in the posterior region. Number of lesions is unilocular and solitary. Size and shape is approximately 13 times 13 millimeters and it's round shape. Extent is superior-inferiorly extending from root apex to the sinus. Periphery and borders, it's well-defined cortical borders. The internal structures is radiolucent, and effect of surrounding structures, it's encroaching the maxillary sinus, there is loss of lamina dura, there is widening of PDL, and there is expansion of cortical borders.
Hello, my name is Lamis Dghariri. I will be talking about the differential diagnosis. Our first differential diagnosis is radicular cyst, which is also called periapical cyst or apical periodontal cyst. It is the most common type of cysts in the jaw. It arises from a non-vital tooth. It's asymptomatic unless secondary infection occurs, which may also cause a swelling. The incidence is greater from the 3rd to the 6th decade with slight male predominance. The epicenter is located approximately at the apex of a non-vital tooth, and 60% are found in the maxilla. It has a well-defined corticated periphery. It's radiolucent with dystrophic calcification that may develop in long-standing cysts. It may cause resorption of the adjacent tooth roots and may invaginate the sinus. The cystic cavity is lined by non-keratinized stratified squamous epithelium. Our second differential diagnosis is simple bone cyst, which is also called traumatic or hemorrhagic bone cyst. It's not a true cyst due to the lack of epithelial lining. It's very common. The teeth are usually vital. It's asymptomatic in most cases, but occasionally pain or tenderness may be present. It occurs in the first 2 decades of life with a male predominance of 2 to 1. It occurs mostly in the mandible. The margin may vary from well-defined delicate cortex to an ill-defined border without a cortex. It's radiolucent and may appear as multilocular, although it does not have a true septa. In most cases, it has no effect on the surrounding teeth. Histologically, the inner lining is composed of fibrovascular connective tissue with intermingled foci of reactive new bone formation and few osteoclast-like giant cells. And as we said, because the cyst walls do not have an epithelial lining, it actually represents a pseudocyst. Aggregates of a homogeneous matrix reported as odontogenic cementum-like material can be detected in the pseudocystic wall, and there is no general agreement concerning the origin or true nature of this substance. Most authors have accepted the theory that calcified fibrin clots are the source of this matrix, but in the referenced article they were not able to detect any evidence of fibrin deposits.
Hello everyone, my name is Shahad Al-Ghamdi and I'll continue the differential diagnosis. Our third differential diagnosis is periapical osseous cemental dysplasia. It's a common bone dysplasia that typically occur in the middle age. The mean age is 39. It's an asymptomatic. It's usually happen the tooth vital. It's associated with the apex of the mandibular anterior teeth. In the early stages, we notice radiolucencies because the normal bone is resorbed and replaced with a fibrous tissue that usually continues with the periodontal ligament and that caused loss of lamina dura. During the histological feature, a fragment of a calcified material exhibits a cell with a numerous of smaller calcified masses that they disturbed in the fibrous stroma. So these calcified fragments exhibit a woven pattern of mineralization with occasional resting and reversal line with a droplet of cementum-like material. Our fourth differential diagnosis is keratocystic odontogenic tumor, developed during the second and third decade with a slight male predominance. Usually have no symptoms. The patient may come with a mild swelling, sometimes arise around the unerupted tooth. There is no pain or discomfort unless the patient have a secondary infection. During the radiographical feature, the cyst may have a smooth or round or oval shape, similar to other cysts, and it may have a scalloped outline. It usually happens to be on the posterior body of the mandible or in the ramus. The internal structure is radiolucent with multilocular appearance in some instances, and its ability to grow along the internal aspect of the jaw, causing to minimal expansion which delay its early detection. About the histological feature, the cyst may contain a clear liquid that is similar to a serum, or it may be filled with a cheesy material, a stratified squamous epithelium. So the epithelium and connective tissue, the interface is usually flat.
Assalamu alaikum warahmatullahi wabarakatuh. My name is Asma Al-Ajmi and I will talk about the histopathological features. The cyst cavity was lined by non-keratinized stratified squamous epithelium with mixed inflammatory infiltration present with striated ciliated cell. As we can see in picture A, this is the non-keratinized stratified squamous epithelium. Roshon hyaline bodies, it's amorphic, isophilic, linear to crescent-shaped bodies found in epithelium of 10% of preapical cyst. So as we can see in the picture D, this is the hyaline bodies and it's surrounding by lymphocytes. Cholesterol cleft are within the cyst lined and multinucleated gain cell adjacent to it. And at the last picture or E picture, we can see the Roshan bodies with a cholesterol cleft. So this is the case analysis. We will compare between the four differential diagnoses regarding to the age, gender, set, shape, internal structure, and effect of adjacent structure. Our case analysis and definitive diagnosis, it's radicular cyst.
Bismillah ar-Rahman ar-Rahim. My name is Nofar Rakban and I'm going to proceed with the last thing, which is the management of the radicular cyst. The management of a radicular cyst would be an extraction, endodontic therapy, or an apical surgery in case of a small radicular cyst. However, in case of a large radicular cyst would usually involve surgical removal or marzipulation. Marzipulation is a surgical technique of cutting a slit into an abscess or a cyst and suturing the edges of a slit to form a continuous surface from an exterior to the interior surface of the cyst. Sutured in this position, the site remains open and can drain freely. So the management of our patient in particular would be an endodontic therapy for tooth 1-6. If the lesion or the radicular cyst didn't subside, we're going to go for an extraction or an apical surgery or even a surgical removal. Since the patient has a history of prosthetic valve replacement, this must be taken into consideration because the patient has a high risk of affective endocarditis. Dental procedures that may cause IE includes first surgery, including extractions, periodontic procedures, interligamental LA only, apical over-instrumentation during RCTs. So we have to check the anticoagulant therapy, especially with prosthetic valve replacements, emphasize on oral health prevention, oral hygiene, fluoride fissure sealants, follow one of the following protocols regarding antibiotic prophylaxis for IE, including either UK or the USA protocols, antibiotic regimen. If the patient is going for a surgical option, antibiotic prophylaxis of 2 grams of amoxicillin or 600 milligrams of clindamycin should be given 1 hour before the procedure of oral dose and 30 minutes before if IV or IM. So these are our references. And thank you so much for listening.